The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I wanted to talk about mechanical ventilation. If you've been a long-time subscriber, if you've been a long-time listener, you know that we did a 3-part series to kind of lead off the podcast about 4 years ago. And we're just about to hit our 4-year anniversary. I thought, since I've learned so much in mechanical ventilation in that 4-year period, things have changed with literature. My ability to explain things have changed. And I thought it would be fitting to kind of go with our theme this last month of releasing the second edition of the Ventilator Management, a Pre-Hospital Perspective. I want to say thank you for all the orders and for all the support on that book. It just has been a really, really rewarding project, and I'm so happy that everybody has received it really well. So we're going to do a 3-part series. I'm going to try to make these kind of more short and dynamic, and then we'll do a few other podcasts related to mechanical ventilation that I think you guys will enjoy. So why don't we start it off? When we think about mechanical ventilation, we have to remember there's some processes in play that are much different than how we normally breathe. And I think the important thing to understand is that we all breathe based on a negative pressure. And based on that negative pressure, our diaphragm, the process of it contracting downward, that causes a pressure change, and it causes a higher pressure inside of our chest cavity. And that basically allows for air to flow in really unimpeded. So that process is very active. It's very easy for us. In contrast, when we deliver a breath based on mechanical ventilation, whether that's a volume breath or a pressure breath, there's some differences there, but that is a much different process. That's delivering a breath based on positive pressure, and that process can be uncomfortable. That process is a little bit non-physiologic. When we think about the opposite, our exhalation process, anytime you place a patient on the ventilator, their exhalation process is going to be inhibited. And that's something that we have to always think about. We have to always have in the back of our mind that we have to optimize their exhalation process just based on them being on a ventilator. And as we move through the first, second, and third part of this series, part 2 will start off and we'll really touch on the exhalation process and how to optimize exhalation and what disease processes do we look at differently with regards to your inspiratory time, your ID ratio. When we continue down kind of how we breathe and we think about the past, right? What did they do in the past? What did they do 20, 30 years ago? Well, we know that a group of researchers came together in 2000, and there were doctors that saw an issue. They saw that mechanical ventilation, tidal volumes, were being delivered in a manner that could be, as far as their hypothesis, harmful to our patients. And they were seeing a lot of patients that had issues with ventilator lung injury, ARDS, inflammatory response. So they hypothesized and they said, maybe there's a better way. Maybe we shouldn't be giving tidal volumes of 10 to 15 mils per kilo. And the mindset back then was, if we give a big tidal volume and we cause optimal recruitment, we fill every amount of alveoli with volume, that they're going to oxygenate better. But they forgot that our alveoli can only handle so much pressure. And excessive stretch, excessively high pressures at the alveolar level, what we know now as plateau pressures, that causes harm, and that leads to inflammatory response. And that inflammatory response leads to ventilator lung injury and ARDS if it progresses significantly enough. And so this group of researchers came together and they said, hey, let's do a trial. Let's look at some good data. And so they did a comparison, and they put some patients on a 6 to 8 mil per kilo tidal volume, and they put other patients on the standard 10 to 12 mil per kilo tidal volume. And I believe they looked at about 861 patients. And once they got through that many patients, the study wasn't done, but they identified, hey, we're really making a difference. There's such a reduction in morbidity and mortality. We need to maybe pull back, and we need to stop this trial. We're doing more harm to those patients that are getting the huge tidal volumes. So they stopped the trial. And that's where we get our lung protection, our quote-unquote lung protective strategies that we use now. And so that range is 6 to 8 mils per kilo. And then when you look at true lung protective strategy, where you have high plateau pressures, you have a baby lung, you have a sick lung, those ranges go down to 4 to 6 mils per kilo. And so we're delivering tidal volumes about half of what we did 20 to 30 years ago. How do we deliver those, though? We need to understand that there's something called dead space. So we have to have the right amount of volume that's sufficient to overcome the dead space. Remember, we deliver a breath, and if that breath is 600 mils based on their ideal body weight, we potentially have the ability to lose 1 mil for every pound of ideal body weight in dead space. So those patients could lose, an average adult, about 150 mils of that 600. So only 450 of that is getting to the alveolar level that contributes to gas exchange. So dead space is something we're going to talk about a lot in these podcasts on mechanical ventilation. And if you've heard me lecture live at a conference or a review class, you know that I'm very big on looking at dead space, understanding what our dead space is, and accounting for that dead space, and realizing that what we put in is not what's reaching the alveolar level. Because ultimately, what we put in does not match what happens at the alveolar level for gas exchange, and that's what's most important. So what do we do for our respiratory rates? If you've heard me speak, and I give all the credit to Scott Weingart, about 8 years ago, he put out a podcast. I think it was one of his first podcasts, and he had some teaching points on this podcast that still stick with me today that I found so profound, I found so amazing as far as its application. And it's a simple approach to mechanical ventilation. And I think we can all say that we get on a patient, these very complex ICU patients, and there's so many things wrong with them that the last thing that you want to do is have to sit there and scratch your head and say, man, I know what tidal volume is, I know what rate is, I know what ID ratio is, but I don't know how to apply it to this patient. This is confusing. And so I think his simple approach of looking at it from, is this an injury approach patient, or is this an obstructive approach patient? And that really gives you the ability to set your rate. Your rate is set off the approach. So if you have an obstructive lung patient, obstructive lung patients are two patients, COPD patients and asthmatics that are obstructed. They have a problem getting the air back out. They have narrowing of the airways. They have brittle airways. They have alveolar atelectasis, potentially. So our whole point is to protect that lung. And we protect that lung, we protect that process, I should say, by setting a lower respiratory rate. We know that if we breathe faster and faster and faster, you only have so much time in a inspiratory phase. And an inspiratory phase is the start of inhalation and the end of exhalation. And so that phase, if it's 6 seconds, if it's 3 seconds, you only have so much time for that inspiratory phase and that expiratory phase. And so it makes sense if you start breathing faster and faster and faster, your exhalation time gets slower and slower and slower. Or I should say, your exhalation time gets shorter and shorter and shorter. So you're spending the entire time constantly taking a breath, and you're never giving the patient, or for that matter, if the patient is breathing very tachypnic, they're never giving themselves the opportunity to exhale. And so just based on that, an obstructive patient should have a respiratory rate set at 10 to 12 per minute. Your other kind of grouping is your injury approach patient. And that injury approach patient is all about protecting the lung from injury. And we do that by setting a lower lung protective tidal volume. If we set a lower tidal volume, we automatically have to set a higher respiratory rate. We set a higher respiratory rate because we have to meet a goal for overall minute ventilation, right? We have to be able to deliver the right amount of minute ventilation to the alveolar level so we have proper gas exchange, so we have proper eucapnia, so we can maintain our CO2 levels in the appropriate ranges based on this patient's disease process or their current presentation. So those respiratory rates need to be higher, 16, 18, maybe 30 a minute if this is a patient that's in metabolic acidosis. And we'll get to that as we progress through this. So your respiratory rate is not the standard 10 or 12, right? We are long past putting a patient on a tidal volume of 500 and a rate of 10. As nicely as I say this on this podcast, because I'm all about mentoring and teaching, that is probably the biggest frustration that I see is when I read a chart or I hear a scenario and that's what's put in the scenario, because that is not adequate as far as alveolar minute ventilation. We have to remember you lose potentially 1 mil for every pound of ideal body weight. That is physiologic dead space. And then we actually have mechanical dead space on top of that. And we'll talk about that as we move through here. So that is substandard as far as delivering minute ventilation. So your respiratory rate in conclusion is all about the approach. And we only have 2 approaches, injury and obstructive. What do we do with our oxygenation? Right? I think if you kind of trace your career back, and whether you started as an EMT or you started as a nursing student, or maybe you were another provider prior to going into nursing, you were taught that oxygenation is everything and that always give as much oxygenation as possible. And I think that's true to a point. Obviously, always give 100% FiO2 if you're in doubt. Patients that are hemorrhaging, hypemic, hypoxic patients, they've lost their ability to carry oxygen. We carry 98% of our oxygen on hemoglobin, so it makes complete sense if you're hemorrhaging and you're losing that ability to carry oxygen, you need to optimize that in whatever way you can, and that is by giving 100% FiO2. But we also know that in long-term administration of high concentrations of oxygen, we have a few issues. 95% of the oxygen that we deliver turns into water. It's converted into water. It's used in the carbonic acid buffering system, and it's used in the electron transport chain as a fuel for aerobic metabolism. The other 5% actually turns into what's called free radicals. Those free radicals are what's called toxic metabolites, and they leak into the cytosol, they move out of the cell, and they start damaging these cellular epithelial tissues. They start attacking proteins and lipids and nucleic acids, and we start having a decrease in what's called protein synthesis. And this is really, really hard on the lungs and the cells. This leads to mucus production. It leads to inflammatory response. It leads to breakdown of what's called the glycocalyx. The glycocalyx is the finger-like projections, hair-like projections on a vessel. And so if you start breaking down that glycocalyx, you start having leakage through that vessel. That's where we start seeing our ARDS start. We start seeing leakage through that glycocalyx, through that vessel into the capillary beds and into the interstitial areas. And so it's kind of a big revolving circle. So we have to know that giving oxygen, it should be something we always do in acute patients. But in these ICU patients, we should always kind of go based on what the ARGINET study has laid out. And that is to immediately drop your FiO2 to 30%, have a PEEP of 5, maintain your SpO2 of 93%. And so you're always changing your PEEP. Your PEEP is always the thing that you're going to be driving upward. And so it may be a FiO2 of 30%, a PEEP of 5, and then you go up from a PEEP of 5 to a PEEP of 8, and you maintain that FiO2 at 30%. And if that doesn't maintain that SpO2 of 93%, then you're now going to increase your FiO2 to 40%. If you haven't seen this, this is called the PEEP FiO2 slide, and you can find this on the ARGINET website. I will put a copy of this in the show notes. I have a copy of this in the book as well. The point is that we always want to use more PEEP than we do FiO2. PEEP is your friend, and really, and I've heard this taught by physicians, that a PEEP of 10 is the old PEEP of 5. And so kind of consider that, right? We want to always optimize oxygenation. We do that in some really simple ways. And if you kind of think about ways we can optimize oxygenation, think about one of the gas laws. And I discussed this in depth in the review class. And one of the most prominent gas laws that we have to think about and always utilize is Henry's Law. And Henry's Law, the classic definition of Henry's Law, is the amount of gas that's dissolved in a solution is directly proportional to the pressure of the gas over the solution. So one of the pearls that I like to teach is this. If the partial pressure, all right, what's the partial pressure? The partial pressure is how are we able to utilize our concentration of oxygen. And the great example of that is that if we're at sea level, you multiply your atmospheric pressure, which is 760, by the percentage of oxygen that you're taking in or delivering, so 21% at room air. And that gives you a potential of about 159. That's your partial pressure. And after dilution, after taking away the water vapor pressure that's in the air, we end up with about a 104, 106. That's our partial pressure of oxygen as we bring an O2 molecule into our mouth. So if the partial pressure of the gas is twice as high, okay, so how do we make it twice as high? Well, the only way to make it twice as high without changing our altitude is by throwing more gas, so increasing the concentration. Then on average, twice as many molecules will hit the liquid. Well, what's the liquid? The liquid is the blood. So I'll say that again. Then on average, twice as many molecules will hit the liquid surface at any given time. So if you throw more gas at the solution, then obviously this gas is going to be captured in the solution based on the solubility of that gas. So Henry's Law is a great way to explain oxygen transport and how that O2 molecule diffuses through all the different layers until it reaches the capillaries, until it reaches the blood. We know that the solubility is all based on how well that molecule diffuses. And we know nitrogen, for example, is the dominant gas that we breathe in, has 78% of atmospheric air. We know that that's a very large molecule, a very dense molecule, and it doesn't diffuse very easy. In contrast, we know CO2 diffuses 22 times faster, easier than oxygen. So each one of the gases that we have in our body, right? Dominant is nitrogen, then we have our carbon dioxide, and we have our oxygen. Each one of them diffuses, their solubility is much different. So how can we use Henry's law to optimize this process? Well, we can do three things. We can increase the concentration and go back to that definition. If the partial pressure of the gas is twice as high, then on average, twice as many molecules will hit the liquid in a given time. So if we throw more gas at that solution, that's automatically going to raise our oxygen delivery potential. Then we need to add PEEP. We need to change the surface area. We need to make the alveoli bigger, give it more opportunity, more oxygen opportunity to diffuse through the alveolar membrane. And then lastly, we have to push that gas into the solution, into the blood. And we do that either based on bag valve mask ventilation with a PEEP valve, or we do that with a ventilator. The point is, just throwing 100% FiO2 at a patient doesn't always fix the issue. We have to think about things on a cellular level of how we can optimize this. And Henry's law is a great example of taking a three-step approach and saying, all right, I'm going to throw more gas at the solution. I'm going to make that surface area so more gas can diffuse through that alveolar membrane bigger. And then I'm going to actually apply pressure, and I'm going to push that gas into the solution. So I think the lesson is throwing more gas at the solution doesn't always fix the issue. It's all three combined. Just raising the FiO2 is not always the answer. It can actually be harmful. As long as we maintain that SpO2 of 93%, that's our goal. Another type of patient that we have to kind of consider is that pregnant mom. That pregnant mom has a huge increase in red blood cells, in FFP, and their ability to offload oxygen is greatly increased. So they're 2,3-DPG. They're little crowbars on their red blood cells, on their hemoglobin. That concentration is increased. So they kind of live at that super normal partial pressure of oxygen. If they get a partial pressure of oxygen that drops below 90 millimeters of mercury, that oftentimes can put them into labor. So we have to always take great care in that pregnant mom to deliver as much oxygen as possible all the time. So the next thing I want to talk about is what's called minute ventilation. And minute ventilation is everything, right? We have to be able to deliver the right amount of minute ventilation to the alveolar level so you have proper eucapnia. We know that minute ventilation is simply your tidal volume times your rate. So how much volume are you putting in over how many times per minute? We know that physiologic minute ventilation is between 4 and 8 liters per minute. And we know that if we reduce that to a simpler form, that's 4,000 to 8,000 mils per minute. We have to remember, though, as I kind of alluded to in the tidal volume section, delivering minute ventilation is much different than what the alveolar level is seeing minute ventilation-wise. So delivering a minute ventilation of 7 liters per minute is much different than an alveolar minute ventilation that's 4.5 liters per minute. And we're going to talk about that more as we get through, I believe, module 2 of this, or part 2 of this. But just know your minute ventilation at the alveolar level needs to be between that range. And then I would argue that it needs to be on the higher end of that range. Think about the patients that we transport, right? These patients are not in homeostasis. They're oftentimes in a, metabolic acidosis. They're in a hypemic hypoxia. They're in a situation where they need a higher amount of volume going through that alveolar membrane. They have to have a higher potential for gas exchange. So if we put a certain amount into the ventilator, how do we know what's coming back out? Well, that's called exhale tidal volume. Most of the ventilators out there transport-wise have the ability to monitor exhale tidal volume. And this is a very important thing. This is the most accurate measurement of volume received by the patient. You're going to have variations breath to breath. You're going to see variations breath to breath. It should just be maybe 10 or 15 mils. It shouldn't start being 50, 60, 70, 100, 150 mils, right? That's where you're starting to look at this from the perspective of a compliance issue. That compliance is getting worse. But XL tidal volume is a great tool, and we utilize it in a couple different ways. The first way is just to identify, all right, I'm putting in 500 mils. What am I getting back out? The question often comes up of, all right, I'm putting in 500 mils. I'm only getting out 400. And the knee-jerk reaction is to say, well, I'm automatically now going to raise my tidal volume up another 100 mils so I achieve that 500. And that's the wrong answer. We have to remember, we have to identify, do we have a compliance issue? Do we have something going on? Is that why we're not getting that volume out? Or do we have a lot of dead space, right? You can't just do a knee-jerk reaction and just automatically say, all right, I'm 100 mils short. I'm putting in 500. I'm getting back out 400. That must mean I need to raise my tidal volume up 100 mils. That's not the answer. If you're within 50 mils, 70 mils of what your ideal tidal volume is, and it's consistently staying that way, I wouldn't worry about it. I'm all about making the smaller changes, right? Don't make changes to the ventilator unless you have to. Set yourself up for success in the beginning and know what's going on, but don't do knee-jerk kind of changes just based on a number. One way we can adjust our tidal volume to kind of compensate for some exhale tidal volume that's a little lower is what's called mechanical dead space. And mechanical dead space is just simply based on the circuit, right? The circuit, the ET tube. But the circuit is something we kind of can identify. And the way to do this is every vent circuit has their actual dead space kind of formula. But a pretty standard dead space formula that I know CareFusion uses for the LTV 1200 and the Revell is, and I learned this from one of the reps, Daniela. She's phenomenal. And she taught me this. And it's just to round your numbers up to make the math simple. And if you've heard my other podcasts, I'm all about that. Little tricks. Make things simple. Is for an adult circuit, right? And remember, for an adult circuit, that's any patient greater than 20 kilos. So if your patient's greater than 20 kilos, they need to be on an adult circuit. You take that circuit is 2 mils, and you multiply by their peak inspiratory pressure. So the ventilator is going to give you that PIP, that peak inspiratory pressure. So 2 mils times their PIP. So that means if their PIP was 22, multiply that by 2, their mechanical dead space from that circuit is 44 mils. So you could actually raise your tidal volume up from 500 to 550 just to account for that mechanical dead space. That's appropriate. That's absolutely appropriate. On a pediatric circuit, that's any patient less than 20 kilos. And so that's 1 mil times their PIP. So again, if their PIP was 22, multiplied by 1, that's 22 mils. You would raise up their tidal volume by 22 mils just to account for that mechanical dead space loss. Again, honestly, when I get on a patient and I have this, that's something I usually don't do. I've found that if my exhale tidal volumes are within a pretty close range of what my set tidal volume is, I'm very happy with that. The other way we use exhale tidal volume is based on pressure control delivery, right? So your mode of ventilation, let's say, is SIMV. You started in volume as far as your delivery. You now switch to pressure. The only way to identify now that the pressure you're delivering is giving you a tidal volume of whatever, right? Whatever your target is by identifying that exhale tidal volume. So if we start with a pressure, inspiratory pressure of 20 centimeters of water, how do you know, other than exhale tidal volume, that you're getting a tidal volume that's appropriate for that patient and their ideal body weight? So in pressure, you still have to identify their ideal body weight. You still need to calculate a tidal volume for you, kind of put that in your head. Start with your pressure of 20. That's an appropriate starting pressure for an adult. And immediately switch the ventilator at the very top and identify what their exhale tidal volume is. Remember, pressure is volume. And I say that as kind of an analogy, right? When we deliver a breath in volume, we identify a pressure, right? We're looking at our PIP, we're looking at our P-plat, making sure our volumes aren't too high. Well, when we deliver a breath based on pressure, we're actually now looking at an exhale tidal volume. So it's kind of opposite. But if your tidal volume is low in pressure, you increase your pressure. If it's high, you decrease your pressure. So the only way to identify that is based on that exhale tidal volume. Very, very important to remember. The last thing we're going to talk about on this part 1 is called trigger or sensitivity. And I use those names interchangeably. So I'm going to kind of focus on the Revell, because I think it's probably the most popular or the most saturated ventilator out there right now, and the LTV 1200, right? I know the Hamilton T1 is making a big surge. I think it's a phenomenal ventilator. It's absolutely amazing. But I don't have a lot of application experience with that ventilator. So the first thing to remember is the LTV 1200 and Revell, for example. Those are flow-triggered ventilators. You compare that with, let's say, the Impact. The Impact is a pressure-triggered ventilator. All right? So remember, it is a flow-triggered ventilator. Most transport ventilators are flow-triggered ventilators, and they're flow-triggered based on what's called a bias flow. The bias flow is the amount of volume moving through the circuit during exhalation. And then based on whatever trigger you have, that flow is diverted and utilized as a triggering mechanism. So the LTV 1200 and the Revell both have the potential for a bias flow of 10 liters per minute, with the LTV 1200 having a bias flow default set at 10 liters per minute, and the Revell actually having it default set at 5 liters per minute, with your ability to go in the back under ventilator config and increasing that bias flow from 5 to 10. So what does a bias flow mean? What does it mean based on a trigger? Well, let's imagine we set a trigger or a sensitivity level of 3. What we're saying is that now the patient has to pull enough volume of 3 liters per minute of flow. They've got to divert 3 liters out of that 10 going through that circuit, through that that's going in circles during exhalation. Well, 3 liters is a big number. So if we do simple math and we reduce that down, what is the simplest form of 3 liters? It's 3,000 mils. And what is the simplest form of 1 minute? That's 60 seconds. So if you divide 60 seconds into 3,000 mils, you get 50 mils a second. So that is a number for me that makes complete sense. So all the patient has to do on a trigger of 3 is they have to divert that flow by 50 mils per second. And that will let them either take a breath in SIMV, or it will trigger the ventilator to give a breath in assist control. If we used a trigger of 5, for example, again, reduce it down. We got 5 liters per minute is reduced to 5,000 mils. 1 minute is reduced to 60 seconds. So we divide 60 into 5,000 and we get approximately 82, I believe, something like that. Do the math real quick. So 5,000 divided by 60. So 83 mils per second. So they have to divert that flow 83 mils per second. So here's the problem with that. Just grabbing the vent circuit on a lower trigger setting, right? 1, 2, even 3. It's very easy to shake that vent circuit and change that flow by 50 mils, right? 50 mils is not very much. And so that's one problem with the transport environment, the transport ventilators. Being a flow trigger ventilator, it's very easy to have auto triggering or to have a triggering event just based on movement or vibration. When we get into the modes of ventilation, I'll kind of explain this in more depth, but that's why I really, really push SIMB in the transport environment. And honestly, a lot of the literature I read, a lot of these hospitals, these level 1 facilities are going with more SIMB. But it's not because it's been proven that SIMB is better than assist control. It's that it gives you kind of a safety net. I would much rather have the ventilator think that it's a triggering event and the patient not take a breath, and then the ventilator maybe give an assisted breath based on SIMB and the way that mode works. And again, we'll get into that in part 2. Then in assist control, every time that circuit is shaken or moved or a vibration triggers that vent, they get a full mandatory breath. That can be a very detrimental thing for our patients. So triggering is something you have to understand. Now, one of the neat things that the Revell ventilator has over the LTV 1200, something that CareFusion improved when they, the engineers kind of invented the Revell, is if you are listening and you don't know this, if you go to your Revell and you just turn the trigger sensitivity knob backwards, so turn it counterclockwise to 1, and now turn it again in counterclockwise until you see the letter P for pressure pop up. The Revell gives you the ability, if you have an auto-triggering phenomenon where you just can't get it to stop, right? Maybe you just have such a vibration issue. I've had this exact thing happen in a helicopter where it found that there was some stabilizers in the belly that had wore out, and there was some excessive vibration, and we were having a lot of issues with the ventilator. The Revell gives you that ability to turn it backwards to a pressure trigger, and it defaults to a -3 centimeters of water. And so that ventilator is really good in that context. It gives you, the clinician, kind of a safety net to where, it's a primary flow triggered ventilator, but hey, I need to do something different. Turn it backwards to P, automatically switches it to a pressure trigger of -3, and now that -3 is at the end of the vent circuit. That patient has to change that and bring that pressure up to 0 to trigger the ventilator. Much different than a flow triggered ventilator. So I think it's very important to understand trigger, understand its application, how it can be a benefit, how it can be detrimental. And understand your equipment. Understand that, maybe we're not setting a trigger to allow the patient to take breaths for weaning purposes, right? Because that's not our role. Our role is to maintain them, do no harm, get them to a definitive facility, optimize their care, but we're not weaning them. So trigger and how we use the trigger and how we understand bias flow and how we understand our ventilator can be a big deal. So I'm going to stop there, I think, for this. I think we're 37 minutes, something like that. Again, I want to say thank you to everybody I met at EMS Expo. Was such a success. Got to meet hundreds and hundreds of people that knew the podcast, wanted to meet me, wanted to meet Mike, wanted to meet my wife. And our supporters of FlightBridgeED obviously made lots of new contacts, got to share what we do, got to share the podcast with so many people. So I feel like it was a total success. And then went right to the Echo conference in Athens, Georgia. Want to give a shout out to Sam, put on a great conference. So very thankful that we were invited to come and speak. I got to speak twice and got to share my book during the pre-conference, ventilator pre-conference that we did together. So very, very cool, very honored to be able to kind of share those things at those events. And again, I just want to always give the invitation. If you ever have a question, if you ever want to talk about a case, if you ever just don't understand something, I really, truly field all phone calls. I'll answer my emails immediately. I give people my phone number, and you can text me, you can call me. That's truly what I'm here for. If I don't have the answer, I definitely will try to find the answer. And that's what we do here is we try to invest in you. So please let me know if you have any questions. If you have any really cool topic ideas, shoot them my way. And until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.